You are tuned into the Dr. Tyna Show with Dr. Tyna Moore. For more, visit drtyna.com. On this episode of the Dr. Tyna Show, I'm going to be sharing with you the 5 hazardous signs of low estrogen that your doctor probably doesn't know, and you probably don't know either. But I saw this in my practice a lot. I personally have experienced all of these symptoms, and I wanted to take the time to make this episode today to share these very specific, nuanced symptomology with you so that you don't get caught in the trap of low estrogen without knowing where you are or how to navigate it. So let's jump in. Hey, real quick, I wanted to make sure that I shared this with you. I have got a free challenge coming up here in the early part of January. As of the airing of this episode, we should have either just gotten started or will be getting started. It is a free 21-day jumpstart. It's called the Strength and Resilience Challenge, and I want to make sure that you guys join me. It's free. This is for anyone of any age, and what we're going to be covering over 21 days is what are your basic strength goals, because you guys need to know what they are so that you have goals for 2025 and you have points that you want to meet, right? It's much better off when we're goal-oriented than if we're just like arbitrarily chasing some idea of things. The next piece of it is going to be that we make sure to teach you the basics of what you need to know about your metabolic health. So this is going to be value packed. I'm going to be sending you guys an email every single day. This is for your friends, your family, obviously yourself, young people, older people. I want to make sure that there's something in there for everyone. So go ahead and head over to drtyna.com/strength and resilience. That's drtyna.com/strength and resilience. The link will be in the show notes. If you're watching on YouTube, the link will be in the description below. Go ahead and click it. Put in your name and email. You'll be on the list for when this starts, or if it's already started by the time this airs, you'll get started right at the beginning. So I want to make sure that everybody has the opportunity to have really tangible strength goals and metabolic health goals for 2025, because I know that many of us have New Year's resolutions, but unfortunately, most of those go by the wayside within the first few weeks of January. So I want to make sure that we do something real and helpful and valuable so that we can move the needle in 2025. I hope you'll join us. drtyna.com/strength and resilience. Okay, so first off, I think some of you have already heard this story, but I want to reiterate. I have been using hormone replacement therapy personally since my 30s. And the way that I function in my clinic is that I treat the deficiencies as they show up. So I don't care how old somebody is or how young they are. I treat what needs to be treated at the time. I base this on symptomology. I base this on testing. I base this on putting the two together, their health history. There's a number of reasons why a woman or even a man might present at any age with a low hormone profile. And it's not my job to judge how they got there. It's my job to optimize their health and supplement in the hormones at physiologic doses that they need. So I'm going to share with you some signs that you may not know about and your doctor definitely doesn't know about, because I cannot tell you the amount of pushback I've gotten over the years for trying to treat patients for these signs and symptoms and having their doctor call me or email me to ask me, what am I doing? And do I even know what I'm doing? But we have data to support everything I'm about to share with you. And we have had the data for some time on many of these signs and factors. Some of them more recently we're getting better data on. So I was right. I was treating people with hormones, getting phenomenal results. So obviously it was the hormonal deficiency that was creating the problem. And lo and behold, they get to physiologic dosing, they feel better. And now we have some really conclusive data on some of these signs. Again, for some of the others, we've had it for a long time. So let's just run through them real quick. I have experienced all of these personally, and I'm going to tell you when, because I'm going to use myself as a case example. When I have been at periods in my life where I was exceptionally thin as a woman, as a menstruating woman, when I have gotten down to my thinnest, where I had 6-pack abs and what I thought was incredible body composition, a very, very low body fat, I was plagued with these symptoms. And we could have pointed at a whole bunch of different things at the time, right? But they all come back now that I'm where I'm at in my age cohort, and now that I'm experiencing the symptoms of actually having your ovaries go offline. It's a subtle decline. And yet in our society, we wait until women are done having ovarian function. So they're done and gone and smoked out in little piles of ash. And then we make them wait until we can get clear testing that clearly shows that they're miserable and in hell. And then we apply hormones, maybe, if they're lucky. It's so ass backwards, you guys. It's so confusingly barbaric and just, I really don't understand it, except I know that most doctors have to follow the standard of care and they're afraid to go off script for, lack of knowledge, lack of losing their license, lack of FDA approval, things like that. But we're allowed to prescribe off-label. And we're also allowed to supplement in based on symptomology as much as lab results. When somebody is suffering, if it's an estrogen deficiency, a progesterone deficiency, testosterone deficiency, we're allowed to supplement in those hormones if we're prescribing doctors. Now, we've got this whole cohort of docs who are, bless them, the chiropractors. I am a chiropractor. I'm also a naturopathic physician, licensed naturopathic physician with a license to prescribe. So I do utilize hormones in my practice and have for decades. I never stopped. Even when the Women's Health Initiative came out with a study showing that oral estrogen and progestins caused issues. And even then, it wasn't terribly well done of a study and it wasn't terribly conclusive. They jumped to conclusions. I have been using topical estrogens, which are deemed safe, and we have data to support that. A great reference for you is Estrogen Matters. That's a great book that you can go check out if you're scared of estrogen. And progesterone, which acts differently on the cellular receptors than progestins. So anyway, all that said, if a woman comes to me and she's in her 30s and she's experiencing, say, infertility or miscarriages or heavy menses or headaches or bloating, we're going to run a hormonal panel, and I'm going to bet you that she's probably got some low or waning progesterone. In fact, I've rarely seen a normal progesterone level in any woman of any age, to be completely honest with you. So it's a very common deficiency to see. And so we're going to supplement progesterone so that she has nice normal periods that stop making her bleed to death every month, right? We're going to see changes in PMS potentially. We're going to see changes in headaches. We're going to see changes in several factors if we can get that progesterone to a level where it's good for her body and she's feeling well and things are proceeding more normally for her. We don't need to wait for menopause for that to happen. Like that's just, I don't know, that's like dark ages medicine to me. We're also going to do that with thyroid hormone if needed, right? Like if a person is presenting with frank hypothyroid symptoms and labs are only slightly off, legally a trial run of thyroid hormone is indicated, and we would track and we would stay in close contact and we would make sure that we're not putting them into any symptom pictures with too high of levels. And we make sure that we are getting symptom relief for the chief complaints that they came in with. So that's how I do things in a nutshell. So that's how this type of medicine is done in a nutshell. The thing that gets missed often is estrogen, because that really is, even in my mind, I was very conservative about handing it out. And it's because I've talked about this on other episodes as well. Estrogen in a body that is metabolically unsound or is carrying around a lot of adipose and in an inflamed state, estrogen goes down funny pathways, and it's not as predictable as when we put it into a fit, lean person. And that's just what I've seen clinically. I have friends who have worked at many of the labs who have corroborated with me on this and told me that they had the same experience seeing this. In some of these lab companies that are utilizing urine or saliva or blood spot, they're looking at different intricacies in the hormonal panels. And while I know this is not gold standard and serum is gold standard, we sometimes use these to see how hormones are going downstream and how they're being metabolized. This has been corroborated. So estrogen or testosterone in a body that is not metabolically sound can be a little less predictable. Progesterone's quite safe, although we still want to make sure it's not doing anything funny or causing any symptoms, right? We want to be resolving symptoms, not causing symptoms. So that said, I have been less generous with estrogen prescriptions, and it's been challenging to decide when is the time to give the estrogen, because in my case and in several patients I've seen, they sometimes would come in with, either weight loss because of stressors that were going on in their life, or maybe they just come out of like an illness, like a, upper respiratory virus that whomped them, and they would lose a decent amount of weight and they would come out and people would be like, oh my gosh, you look amazing, but their estrogen had bottomed out. Chronic stress can really do a number on this, is a big one. And that's what I probably saw most often was women going through incredibly stressful times. They could have been in their 30s. They could have been in their 40s. They were menstruating regularly, or maybe they were having some difficulty with menstruation, but it was still pretty clockwork. And they were simply just on the struggle bus. Now, this doesn't mean that hormonally their ovaries were petering out. It means that their HPA axis was compromised and that things were not proceeding as needed for the body to be in an ideal homeostatic state, and they were experiencing low estrogen symptoms. Conversely, we might see estrogen dominant symptoms, and people say, oh, well, they have plenty of estrogen then, their symptoms match up with high estrogen. Well, maybe, but maybe not, because you can have low estrogen in comparison to your progesterone. The ratio's off because the progesterone's so low that you're now dealing with estrogen dominant symptoms, but they really still have too low of an estrogen. So this can all get very complicated, and I'm not trying to go there with it, but I want you to understand that you can be any age. You're not the TikTok sensation and Instagram online. I'm seeing women in their 30s saying, I'm experiencing premature menopause. Maybe your system is just fried out and your hormones are all zeroing out. I have experienced this personally, and I've seen it countless times. I remember one time running my hormones and getting the lab results back, and literally everything was just zeroed out and flatlined. And I was like, oh shit. And I turned the paper over and put it face down and immediately called my ND, my colleague, and said, hey, I need to come in. We got to sort this out. I was under tremendous stress. I was going through a divorce. My dog had just been hit by a car and lost a leg. She had spent a week on the run before that. So this was also during finals week where I was in 2 medical programs concurrently taking finals from both schools, driving across town. It was crazy. And I was dealing with walking pneumonia, and I was about 115 pounds. So it's like 25 pounds lighter than I am now. And it was terrible. And I had no hormones. And my breasts were deflated. My face was droopy and saggy. My labia was deflated. I mean, everything was deflated on me. My tissues were sort of sagging off of me, and I felt awful. And I had no tolerance bands for anything. All I wanted to do was cry and sleep. I didn't want to eat. I was just absolutely bottomed out. That was not premature menopause. That was my HPA axis getting hammered. My mitochondria were probably getting hammered. I wasn't making any hormones to the levels that I needed because all systems were gone awry. This happens. And so I don't want you to jump into this whole online sensation of young women screaming premature menopause or screaming, I have estrogen dominance. It's like they understand this much of the iceberg, right? They're just understanding the very tippy top. And then the inmates start running the asylum. So I'm here to tell you that you can have transient hormonal lapses. And I believe clinically, and this is not medical advice, but I believe clinically that is the time to go talk to somebody who knows what they're doing and consider physiologic doses of hormone replacement if indicated for you as an individual deemed by your health professional who knows what they're doing. You're not going to get this out of your general GP. You're going to get this out of probably a functional medicine doctor or a more holistic doctor. And I know there's endocrinologists out there screaming right now, and I know there's people having a fit. I see it all the time online. They come at me, but I'm telling you, if somebody's hormones are bottomed out, another example would be a young man who's had excessive head injuries, maybe due to hockey or due to surfing or due to football. I've seen all of the above. And these guys come in their 30s and they have no testosterone and they are plagued with symptoms. They've got chronic pain. They've got migraines. They've got all kinds of issues, and they can't sleep. They can't eat. They can't put on muscle. They can't heal well. These guys have had their heads knocked in enough that now their testosterone's low. So that's just an example. There's all different types, but it is my clinical belief that it is indicated per individual assessment that those patients could potentially benefit from some transient or maybe even cyclical long-term hormone replacement, depending on what their needs are as an individual after assessment. So I'll leave it at that. Here are some symptoms that your doctor very definitely doesn't know about, and you probably don't know either. And I want to make sure that you hear them, because for you perimenopausal ladies, you might be experiencing these. You might be experiencing these as a younger woman hearing this. I know I did in my 30s off and on. And again, it was times of high stress when I was very, very thin. Why is that? Your fat helps you make estrogen. So if you are missing fat, you're not having enough of, or as much of a enzyme called aromatase, converting your androgens into estrogen. And so you are functionally low estrogen, potentially. And that was the case for me. And so I was experiencing these terrible symptoms and feeling awful and didn't know what it was, but it was transient in those cases. It would come and go. And so I've used estrogen transiently as needed until more recently, I finally got myself moved from a topical cream, which I got to say, after years and years and years of prescribing, I'm just not as big of a fan of. I was even up to a few months ago, but there's so many variations that can occur. The time of day you apply it, the time of month you apply it, how hydrated you are, how dried out your skin is, how thick your skin is, how much adipose you have, how much inflammation you have. All of those things could very potentially impact the absorption rate of that topical estrogen cream. I think progesterone creams can be very wonderful for a large variety of cases. And again, until we hit that very close to menopause age where your your periods are starting to shift and it's noticeable and you're starting to definitely have some symptomology, that's when I switch to an oral micronized progesterone. And that's when I'm going to probably put a patch on a patient, because the patch is what I call steady state. So the patch is going to give us more of that steady state so we can start to predict levels better. We're going to start to see a more leveled out absorption. We're going to start to be able to predict with more clarity how they're going to feel on that. And it's easier to on-ramp them into the hormones. We have to on-ramp hormones. It takes like 90 days, really, at least, to get women feeling dialed in and really hitting that sweet spot of where they feel best. And sometimes what happens, and this is very common with peptides as well, is you end up, the tissues absorb and the levels start to increase in the body. And depending on the half-life, you end up with maybe a little bit too much. And so you got to back down a little bit. And so there's just this, it's a dance. It's a elegant dance where the clinician is involved regularly, the patient is giving good feedback and maybe journaling and keeping track. And you've got to figure out where that sweet spot is, especially if you're dealing with several of the hormones and peptides. Like, you can't just throw them all in at once, right? So that said, I think estrogen often gets skipped or overlooked, and it could be a critical piece of the puzzle. I know it was for me, and I know it was for so many patients. One of the first things I learned was from a patient who'd been medically induced into menopause, meaning she'd had a hysterectomy at a young age. I know this is the story for a lot of you women listening, and I don't know all the reasons why women get hysterectomies. I mean, I know medically why they're supposedly indicated, but I cannot think of many reasons at all why they would be clinically indicated. I think that it is a barbaric and short-sighted procedure in many cases. Many cases, these women had some kind of autoimmune situation going on, and or they simply just needed to get their health together, and their health was in shambles, and so they were presenting with ovarian cysts and all kinds of different issues. I've seen cysts, cyst-filled ovaries come back to a more normalized state without having to be removed when the patient's health is really optimized. But that's a process, right? And so we're like a quick trigger medical society where we just like, oh, let's just cut it out. And then these women are thrown into medical menopause, and it's a disastrous place to be. And so this woman told me one day, she said, she hadn't really pre-planned, as many patients do. They don't plan well. And in not planning well, she didn't have her labs ran. And I really needed labs to be, legally from my side, I need labs every so often to make sure that we're doing the right thing. And I was not going to refill her estrogen without having labs. And she had completely she'd kind of just been sort of mamsy-pamsy about it, thinking I would refill it. And I had already given her like a 30-day bumper. So we were in a little bit of a pickle, and she started melting down in my clinic. And she said, if I don't have estrogen, I am in so much horrific pain. I can't see straight. I can't function. So needless to say, I gave her another bumper to get her through to get the labs done so that we had, our T's crossed and our I's dotted, because we both have responsibilities, the patient and the doctor, to doing proper and good medicine. And she needed to uphold her end as well. And I obviously wasn't going to leave her high and dry, because that would not be the ethical thing to do either. So we got her through, everything was fine. But when she said that to me, I had not up until that point appreciated what estrogen, the impact it can have on pain when it's low, the amount of pain somebody could be living in. And it could be anywhere. It could be knees and hips, I think, are very common. Patients will, bilateral, you'll start to see a lot of bilateral pain. For me, it was crippling spinal pain, like bone splitting spinal pain, where to the point where I couldn't even be hugged. It was so terrible. And estrogen in a steady state patch has been miraculous for that. So joint pain and stiffness, especially if it comes out of nowhere, especially if it's bilateral, especially if you're starting to have aches and pains in areas where you haven't had trauma, you just suddenly have pain, I want you to think about estrogen. And I want you to think, have I been through tremendous stressors recently? Have I been through a tremendous illness recently? Have I had a tremendous weight loss recently? Many, many times in my clinical practice, I saw women come in with either tummy tucks or significant weight loss, and just all of their hormones bottomed out. So this is where estrogen plays a role. And we have good data on this. So there's a couple mechanisms I want to share with you. Estrogen has anti-inflammatory properties and helps regulate the body's inflammatory response. With its decline, inflammation can increase in the joints, leading to pain and stiffness. Studies suggest that postmenopausal women often experience new onset joint pain, particularly in weight-bearing joints like the knees and hips, like I said, especially if it's bilateral, guys, due to the estrogen, the natural course of estrogen withdrawal. Tendon and ligament integrity, collagen production. Estrogen supports collagen synthesis. It makes us more juicy, more elastic, which is critical for the strength and elasticity of our connective tissues, including most obviously our tendons and ligaments. So you'll start to see tendon and ligament tears. And that is not fun. That was what I was getting constantly, these little micro tears. And they were so painful because where ligament and tendon meet bone is called the enthesis. It's highly innervated. This is where my entire practice revolved, was around the enthesis. This is where prolotherapy and regenerative injection therapies really shine. And these women would come in with like every other month. They were like, "Doc, I don't know what's going on. You fixed this, we were fine. And then that pulled and tore that." And these little micro tears. The absence of estrogen can also lead to changes in the biomechanics of the joints and soft tissues and actual cartilaginous changes, increasing susceptibility to injuries and chronic pain. Muscle repair and regeneration. We have stem cells that are estrogen dependent, and without them, we can't have these satellite stem cells activate and help initiate repair and regeneration of the muscle. And we won't have muscle protein synthesis as readily with the estrogen decline. So these are really important factors if women are losing muscle with each decade of age. And even if they're strength training, I was still losing muscle. That's when I knew something was up. I was like, why am I still losing muscle? Even with taking testosterone, I needed more estrogen. Estrogen modulates neuromuscular efficiency, so its loss can increase muscle stiffness and tension and aberrant firing of the muscle. So you'll see muscle twitches, muscle fasciculations. There's all different types of symptoms, that even pins and needles feeling that people will perceive, nerve sensations, pain perception that wasn't the same. We've got central sensitization, which that's a whole long other conversation, but central sensitization is a wind-up pain phenomenon in the central nervous system that affects the periphery, and it can happen after any of the things I mentioned, like severe stress or severe injury or severe health compromise from something. It's really a pickle to be in. And I do believe now, looking back after all my years of clinical practice and then my own personal experience with central sensitization, that I think often it might be an estrogen deficiency. Not entirely, that's not the only cause, but we will start to see this microglial wind up in the brain. Neuroinflammation will drive it, but I do think that estrogen plays a role here. So a decline in estrogen can enhance pain sensitivity by upregulating pain receptors. Like it literally upregulates your pain receptors, you guys, and reducing the production of natural pain inhibitors like your endorphins. So this is an amplification of pain perception that's happening in the central nervous system. We get neuropathic pain. Estrogen deficiency has been linked to neuropathic pain conditions, as estrogen contributes to nerve health and function. cartilage degradation. The cartilage gets all kinds of crazy messed up. Estrogen decline will actually lead to declining metabolic sensitivity and insulin sensitivity. So you start to get increased insulin resistance, and because of all the other things I mentioned too, and that increase in insulin resistance will actually start to impact the joints. You've heard me say before, and I've done a whole podcast about it, that osteoarthritis is diabetes of the joints. It is. It's not that simplistic always. I do mention that hormones are a big player here. I have said that all along. This is where that menopausal musculoskeletal syndrome comes in. This is something that I've been treating in my clinic for decades and decades, and something my mentor was treating before me and taught me about. And I'm really glad it's coming on the scene and being noticed by wonderful doctors like Vonda Wright. However, we need more people being aware of this, because as your estrogen declines, you start to get degradation in your cartilage, and you also start to get the insulin resistance having an impact, and leptin in the joint, in the actual joint. Those signaling peptide hormones impact the cartilage health and healing and how it functions and its elasticity, and is it springy, and is it lubricated, and all of those things. And if it's not in good harmony, you start to see degradation, and that now we get pain. And once the cartilage starts to degrade, it's really a downward spiral from there. So we need estrogen on board to have good, healthy joints as we age, because estrogen helps maintain cartilage health by reducing the expression of enzymes that degrade cartilage. Its absence can accelerate cartilage loss, leading to joint instability and osteoarthritis associated pain. So your osteoarthritis is your metabolic health comboed with your hormones, comboed with your activity level. If you're not moving, you're not going to actually have any kind of ability to pump nutrients and hormones in and pump out the metabolites that we need to get rid of, the trash. You're also not going to get load on the cartilage so that it responds appropriately. So we don't want to overdo it, but most women in middle age are underdoing it, because when you cut the ovaries out of rodents, they go in the corner and they stop moving. And I would say the same thing happens to women. They gain belly fat, they go in the corner and they stop moving. And I know for me, when my estrogen was on sharp decline, I just didn't want to do anything. I didn't want to move. I didn't want to exercise. I didn't want to do anything. It makes you antisocial. It makes you not want to move much. It makes you tired and slow and lethargic, and you don't know what's wrong with you, and it makes you flat, which I'll get to in a second. And then lastly, microvascular health. Blood flow to your tissues in general are enhanced when you have enough estrogen on board. So estrogen enhances microvascular blood flow and supports tissue oxygenation. Without sufficient estrogen, reduced blood supply can lead to tissue ischemia, which is where you have lack of oxygen and it clamps down. Your actin and myosin of your muscles lock, and they don't unlock without the presence of oxygen. And thyroid hormone. Thyroid hormone is a big player in all of this too, ladies. I've said it before. I've done podcast episodes about it. If you're over 40, very seriously consider some amount of thyroid replacement as a potential need, because it's a longevity tool as much as anything else. But a little bit of thyroid on board can be incredibly helpful as we move through this transition period. All right. Ripping of tendons and ligaments. This is another cardinal sign. So cardinal one sign was the bone splitting pain, joint pain. Number 2 is ripping of tendons and ligaments. I already mentioned earlier, estrogen makes us more juicy, more elastic. Without it, we start to tear and rip. And again, it's at that enthesis point. So I've already covered this part, so I won't beat a dead horse on this, but lack of estrogen makes you more susceptible to injuries, and it impairs the healing process. So you will start to rip and tear more, and you won't know why, and it's much harder to recover. We don't want that. It's pretty hard to work out when you keep tearing yourself apart. Number 3 cardinal symptom that your doctor does not know, but hopefully is starting to know more often now because of the work of Dr. Lisa Mosconi, is severe brain fog. And I mean severe. It's not just forgetting why you came in a room. That's one part of it. But suddenly you're like in a lethargic brain fog where it's a flat affect kind of brain fog. And you start to feel like you're losing your mind, because estrogen influences our neurotransmitters and modulates them, like serotonin and dopamine. And a decline in estrogen can lead to all kinds of brain symptoms like brain fog, memory lapses, difficulty concentrating, worsening of ADHD symptoms. You maybe didn't even know you had ADHD until you hit menopause or your estrogen bottoms out and you're like, oh my gosh, what is going on? You used to be able to do 5 things at once, like a demon, speed demon, and you were good at it. And now all of a sudden it's utter chaos. It's very frustrating. Low estrogen is associated with cognitive changes and also sleep disruption, which is going to impact your brain functioning during the day. Go look at Dr. Lisa Mosconi's work. She wrote a great book called The Menopause Brain. It's a great book. Go read it. You'll understand better. Your brain starts to upregulate estrogen receptors as a side effect of trying to sop up any and every bit of estrogen that's in the system. And it's looking for it because it needs it. The fourth symptom your doctor probably isn't recognizing as low estrogen is devastating depression and flat affect. I saw Dr. Mary Claire share a study a year ago or so on her Instagram saying that the highest suicide rates in women were in middle-aged women. And this was a UK piece of data. And it was just heartbreaking for me because I've known women who have taken their lives after they've raised their kids, after everybody moved away, and everyone said, oh, it was empty nester syndrome. They didn't know what to do with themselves. No, I think their estrogen probably bottomed out. I suspect that a lot of women, even young women who are dealing with devastating depression, might want to look into their estrogen levels. And I admit I have not been as generous with prescribing it to women in that age cohort, but I think that that's something worth looking at because what happens to those women? They get put on birth control. That might give them a little bit of synthetic hormone to hold them over. A lot of older women get put on birth control. They're told they're being put on HRT and they're just being put on birth control. And it's a disservice in my opinion, but at least they're getting some estrogen. And so I've seen young women go on birth control and actually have their mood improve. I've also seen it send a lot of young women into crazy town, right? And just utterly unwind them. So this reduction in estrogen levels, especially, let's go back to our age cohort here, to the Gen Xers. It can lead to mood swings, depression, and a flat affect that I can't even describe, but it's like an utter not giving a shit about anything. And while some of that's welcome as we're in middle age, like it's kind of nice to hit 40 or up to 50 and be like, oh, I don't give as much of a shit about things. Like that is pretty rad, I will say. It's one of the perks of middle age. But this cognitive decline coupled with potentiation of ADHD, coupled with this super flat affect and devastating depression that cannot be touched. And these are the women that don't respond well. They get put on SSRIs like, oh, you're fine. You don't need hormones. Here's some, Prozac or Effexor or whatever. And it just doesn't really work. It's because they need estrogen, not an SSRI. Now, granted, there is some upside to SSRIs. I'm not dogging them. I really am not. Like I have seen those medications change lives, but all that to say, if you need estrogen, you need estrogen. And so for these middle-aged women having these terrible sudden onsets of depression and flat mood and just utter apathy and just wanting to check out and brain fog and just wanting to lay down and not move, and then couple that with tremendous bone-splitting pain, something is wrong, right? Let's look at the most obvious. When we hear hooves, let's think of horses, not zebras, right? So let's look at the most obvious. And also these women are thrust into autoimmune disease. This is the age cohort that, because of the waning estrogen and progesterone, they get thrust into immune dysregulation and autoimmune disease. So they usually get sent down the like DMARDs, autoimmune route of medications, when in reality, dialing in their lifestyle and their metabolic health coupled with some HRT and potentially, sprinkling in some personalized doses of GLP-1s, which have been showing in the literature to have impact on the immune system and so many other systems. You guys have heard me talk all about that. I have a whole series of podcasts about that. All that to say, the hormones are really critically important here. Another symptom that your doctor probably doesn't appreciate as waning estrogen, and that you may not either, is all-consuming anxiety. I'm talking crippling anxiety out of nowhere. I'm talking anxiety like you had when you were in college. If any of you were plagued with panic attacks as a young woman coming into adulthood, you know exactly what I'm talking about. It is a crippling, consuming anxiety. Or maybe you've been hit with bouts of this type of anxiety throughout your life. I want you to think hard. When was it? Was it after you had a baby? During a hormonal shift, right? Was it going on or off birth control pill? When was it? Was it when you came into, puberty? When did this anxiety strike you? Was it when you were really thin and maybe low hormone? So when was it? These fluctuations, I think The fluctuations are the thing. This is why I think that the topical creams may not be the answer. This is my issue with a lot of the online telemedicine companies that are using creams only, is that it's the fluctuations. It's not so much the lows or it's not so much the levels in general, is the fluctuations. And in all the data that's coming out lately about estrogen and pain, that seems to be the one thing I keep seeing pop up, is it's the fluctuations. And so the fluctuations in estrogen, which are more often when you're either like white knuckling these transition periods of perimenopause and menopause with no hormones, like those of you out there that want to be purists, good luck. That's not me. I don't see any point in suffering at all. But you do you. And I think that the other cohort would be the topicals, because they're using a topical. And I was really kind of mamsy-pamsy about when I used it. I would like use it in the morning, or I'd use it in the evening, or I'd forget to use it, or I'd use it on dry skin, or I'd use it on really moisturized skin, or I'd use it in different areas of my body. And I wasn't getting consistent absorption. And so these fluctuations in estrogen can lead to the pain, and they can lead to the imbalances of the neurotransmitters, which could potentially add up to increasing anxiety levels. And so you add that to this flat affect or this depression, this desire not to move, the pain, the brain fog, the feeling like you're literally losing your mind. And then in between, you get these tremendous bouts of anxiety. That was when I knew that I needed to switch up my estrogen, as I was starting to get crippled by anxiety out of nowhere over nothing. There was like no logical reason for it. And I'm pretty logical. And I usually can stop myself. I mean, I've had anxiety and depression my whole life. But I think I've had estrogen issues my whole life, and progesterone, all the hormones. I remember having like a full on feeling like I was going to have a heart attack bout of anxiety several months ago out of nowhere for no reason. Like there was nothing that was warranted to instigate it. And I thought something is wrong. This has got to be my hormones. Like something is not adding up here. So that's when I slapped on a patch. And you know what? The very next day I woke up feeling like I was floating on a cloud, like I'd taken some kind of sedative. And it was just estrogen. And I was like, oh, this is lovely. So estrogen has a very calming effect on the brain. So does progesterone. Oral progesterone turns into allopregnanolone in the brain. And it is a wonderful, wonderful neuropeptide that just calms everything down. So all that said, consider the hormones, particularly estrogen, if you are in that age cohort and you're starting to experience anxiety, or if you're in any age cohort, just start to look at the symptoms and the scenarios that I'm discussing here and see if any of this adds up for you. And then the very last thing that I will add that maybe your doctor knows and you might actually be paying attention to is labial and facial aging and atrophy. I say this because I hear from women a lot, and I had a lot of patients come in who actually would present with chronic UTIs. These were young women. These were older women. These were women postmenopausal, premenopausal, you name it, women in their 20s, chronic UTIs. Yes, we want to do all the things, right? We want to switch to cotton underwear. We want to make sure that we're eating a really good, diverse diet that's not full of crap and garbage, right? We want to make sure that they're exercising, but that they're taking off their sweaty undergarments and changing their pants and frequently, that they're not wearing a lot of synthetic leggings, all the things, right? We want to make sure that their pH is balanced. We want to make sure that they're getting some fermented foods in their diet. Like I love sauerkraut, for instance, or pickles, kimchi, kefir, whatever. All of that, yes. We want to make sure that they're taking a good look at who their partners are, because a change in partner is a change in flora, and not everybody's flora is compatible. So we want to make sure to take all that into consideration. But I will tell you, one of the best things that I have used for decades for chronic UTIs is topical estriol. It's a form of estrogen. You have three main forms, and this is the most, what they call the weakest form, if you will. It's the form you make when you are pregnant. And it is a wonderful topical for tissues, so the face and the labia in particular. And so a topical estriol can be an absolute game changer for a woman who's dealing with chronic UTIs. Now, what's happening for the menopausal or postmenopausal woman is as she's losing estrogen, her tissues will start to atrophy. We'll start to lose the plumpness and vitality of our tissues. So our face gets kind of saggy and dull, or a lot saggy and dull. The same thing happens down there. And when those tissues begin to atrophy, it's more prone to infection. And so I've seen lots of women who were, maybe their spouses had already passed away. I'm talking much older women in their 70s and 80s even, and they were dealing with chronic UTIs, and topical estriol was the solution. So something it's very easy. It's very safe. Your vaginal estrogen doesn't seem to really impact your systemic estrogen. So this is something that I use clinically in addition to using an estradiol estrogen topically. So I prefer, like I said, the patch. That's an estradiol. That's E2. So consider that. But we can also put it on our face. And I have noticed lately online, there's a big movement all over social media that everybody's like just discovering that you can use estriol on your face. You can use estriol on your face. For those of you who are like, you look so different. Well, I started using GLP-1s, which started mitigating my immune response better. I firmly believe that, like significantly moderating my immune response. So just like something like low-dose naltrexone, GLP-1s, I have seen clinically have the same impact, not just for myself, but for many of my patients. That is what I'm using it for. So when you have that mitigation, you start to look different. For me, my autoimmune disease really shows up in my face. Secondly, when I am very regular with my estriol, my face looks different. Everything's plumper and nicer. When I'm regular with my patch and I'm consistent with that, that has allowed me to, you look different when your estrogen's dialed in. You look different depending on what hormone you're using. So I'm hearing that from people. Yes, I also had an upper bleph. I did a whole podcast episode about it. I've been very transparent, but it's the estrogen. Like that transformation over the past year and a half that people have been commenting on, that's the estrogen. That was me really needing some estrogen and not getting the type that I needed to get the steady state. And then the estriol topically. So when you start to, well, you can also get sagging and drooping with low progesterone too. So it's all the hormones. They go together. I never use one without the other. I might use progesterone for younger women without the estrogen, but I'm talking in our age cohort, perimenopause, menopause, like both. We use both, and then I'll often throw in testosterone too if needed. So decreased levels of all the female sex hormones will lead to atrophy and sagging of tissue. So you'll start to see it in your face. You'll start to see it in your labia or potentially experience it down there. You might not notice UTIs. You might just notice lack of lubrication, lack of libido, maybe pain with intercourse or discomfort, or maybe you're just like, this is not working. I'm not that into it, or difficulty climaxing. Those can all be because of low hormones. So worth noting, dryness, wrinkles, anywhere. Itching of your skin, if things start getting really itchy, those are all signs that you probably need some hormone, especially if you are a Gen Xer like me. So I hope this information is helpful for you. In the meantime, subscribe, rate, review. If you want to get on my email list, that's where you're going to get first notification of anything that I drop, and obviously the best rates on anything that's new that I come out with. So any courses or programs are going to be offered up to my VIP list first. So you can get on there by going to drtyna.com, and there's a couple different places for you to opt in. One of the best is my freebie. It's the Assess Your Metabolic Health Guide. It's the International Guidelines for Metabolic Syndrome. It's designed for you to take an assessment at home of your metabolic health, but also to print it off and take it to your doctor and have a conversation. Go get worked up early in 2025 for metabolic dysfunction. Go get it checked out. Make sure that you know where you stand, because you cannot have happy, healthy hormones, and you cannot have any kind of good response long-term to hormone replacement therapy if you are not metabolically dialed in. Period. And I will die on that sword. So with that, I will bid you adieu. Thanks so much for being here, and I'm really looking forward to 2025 with you. Thanks for listening to the Dr. Tyna Show. This is a Wellness Loud production produced by Drake Peterson and mixed by Mike Fry. Theme song is by John the Guilt. You can watch the full video version of this podcast inside the Spotify app or on YouTube. As always, you can email the podcast at podcast@drtyna.com. That's DRTYNA. And if you like this episode, please rate, review, and subscribe on your favorite podcast app. You can also find all of my offerings on my website at drtyna.com. For more shows by my team, go to wellnessloud.com. See you next time, and thanks for listening. This podcast is for general informational purposes only. It does not constitute the practices of medicine, nursing, or other professional healthcare services, including the giving of medical advice. I am a doctor, but I am not your doctor. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is intended not to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.